If you're listening to this podcast on YouTube, for a better experience, switch to the video version. The link is in the top right corner of the video and in the episode description. Hello and welcome, I'm Fernando, a GP in the UK. Today we will go through the new NICE guideline on acute asthma, or NG244, focusing on what is relevant in primary care only. Just like the NICE guideline on the management of chronic asthma, the NICE guideline on acute asthma is also a collaboration between NICE, SIGN and the British Thoracic Society, or BTS. It replaces previous guidance, and you can find a link to it in the episode description. In this episode, I will just focus on the treatment of acute asthma in adults. In the last episode, we covered the initial assessment in adults, and in the next 3 episodes, I will cover the assessment of children, treatment in children, and lessons from asthma deaths. So stay tuned for those. Right, let's jump into it. When managing acute asthma in adults, our primary goal is to prevent poor outcomes. Many asthma-related deaths are due to clinical staff failing to assess severity with objective measurements, patients or their families underestimating the severity of the attack, and the underuse of corticosteroids. The treatment of acute asthma depends on the severity of the attack, which can range from moderate to life-threatening. For a refresher on how to clinically differentiate between the various severity categories, you can refer to the previous episode on this channel. But before looking at the specific treatment recommendations for each category, let's look at some general treatment principles. Many patients with acute severe asthma are hypoxemic. We should give oxygen to those who are hypoxemic, and the flow rate needs to be adjusted as necessary to maintain oxygen saturation between 94 and 98%, while being cautious to avoid over-oxygenation, especially if there are concerns about hypercapnia. If pulse oximetry is unavailable, oxygen therapy should still be initiated without delay, and oxygen saturation monitoring started as soon as possible. We should also monitor and record the patient's heart rate regularly. In most acute situations, high-dose inhaled beta-2 agonists act rapidly to relieve bronchospasm with minimal side effects, so high-dose inhaled beta-2 agonists should be given as early as possible, ideally nebulized with oxygen rather than air to prevent desaturation, particularly in cases of acute severe or life-threatening asthma. When using oxygen cylinders, it's important to fit a high flow regulator and maintain a flow rate of at least 6 liters per minute to drive the nebulizer effectively. However, if oxygen is unavailable, this shouldn't prevent us from administering nebulized therapy when clinically indicated. Peak flow readings should be recorded before and after administering beta-2 agonists. For patients with severe asthma who respond poorly to initial beta-2 agonist therapy, we should repeat beta-2 agonist doses at 15 to 30 minute intervals, or use continuous nebulization of salbutamol at 5 to 10 milligrams per hour while arranging hospital admission. However, higher bolus doses such as 10 milligrams of salbutamol are unlikely to offer any additional benefit. Also, all patients experiencing an acute asthma attack should receive adequate doses of oral steroids. Steroids significantly reduce mortality, relapse rates, hospital readmissions, and the need for further beta-2 agonist therapy. The earlier they are administered, the better the outcome. Oral steroid tablets are as effective as injected steroids, as long as they can be swallowed and retained. Therefore, we should normally start and continue prednisolone 40 to 50 milligrams daily until recovery and for a minimum of 5 days. While giving systemic corticosteroids, we will not discontinue inhaled corticosteroids. After recovery, oral steroids can be stopped abruptly without tapering, provided the patient is on inhaled corticosteroids, except in cases of prolonged steroid use for 3 weeks or more, or if maintenance oral steroid therapy is planned. Nebulized ipratropium at a dose of 500 micrograms every 4 to 6 hours can be added to beta-2 agonist treatment for patients with acute severe or life-threatening asthma, or those who respond poorly to initial beta-2 agonist therapy. This is because combining nebulized ipratropium with beta-2 agonists provides greater bronchodilation, leading to faster recovery and shorter hospital stays. However, in milder asthma attacks or after stabilization, anticholinergic treatment is not necessary and offers limited benefit. Intravenous aminophylline should only be considered in secondary care because it carries a higher risk of side effects, including arrhythmias and vomiting. Current evidence does not support the use of oral leukotriene receptor antagonists in acute asthma. And equally, routine antibiotics are not recommended for acute asthma because most asthma exacerbations triggered by infection are viral rather than bacterial. And we should therefore only consider antibiotics when there is clear evidence of bacterial infection guided by objective clinical measures. Right, let's now look at the specific treatment recommendations for each category of severity of the asthma attack. And let's start with moderate asthma. Here we can treat the patient either at home or in the practice and monitor the response. For less severe asthma exacerbations, we can start by administering a beta-2 bronchodilator using a spacer, delivering one puff at a time with tidal breathing. According to the response, we can give another puff every 60 seconds up to a maximum of 10 puffs. If the patient doesn't improve or the exacerbation is more concerning, we will escalate to a nebulizer, preferably oxygen-driven, with salbutamol at a dose of 5 mg. We will also give oral prednisolone 40 to 50 mg and then either continue or increase the patient's usual asthma treatment. If the patient responds well to the first round of treatment, meaning their symptoms improve, respiratory and pulse rates settle, and peak flow rises above 50%, they can continue or increase their usual therapy along with daily prednisolone until recovery, and for a minimum of 5 days. However, we will admit the patient to hospital if they show any life-threatening features, they develop symptoms of acute severe asthma despite initial treatment, or if they have a previous history of near-fatal asthma. We should also consider a lower threshold for admission if the attack occurs in the afternoon or evening, there are recent nocturnal symptoms or previous hospital admissions, the patient has experienced severe asthma attacks in the past, they're unable to assess their own condition, or there are concerns about their social circumstances. Next is acute severe asthma. For them, we will consider hospital admission. We will start by administering oxygen to maintain oxygen saturation between 94 and 98%. And we will use a beta-2 bronchodilator via an oxygen-driven nebulizer with salbutamol 5 mg, or if a nebulizer is unavailable, we can use a spacer. And we will give prednisolone 40 to 50 mg, or, if available, IV hydrocortisone 100 mg. If the patient does not respond to this treatment, we will admit them urgently. When referring a patient to hospital, we will stay with them until the ambulance arrives. We will provide a written assessment and referral details and continue administering the beta-2 bronchodilator therapy via an oxygen-driven nebulizer during transport. For life-threatening asthma, we will obviously arrange immediate hospital admission, and in the meantime, we will give oxygen to maintain oxygen saturation between 94 and 98%, administer nebulized therapy via an oxygen-driven nebulizer with salbutamol 5 mg and ipratropium 500 micrograms. If neither the nebulizer nor ipratropium is available, we will use beta-2 bronchodilator via spacer. And we will give prednisolone 40 to 50 mg or IV hydrocortisone 100 mg immediately. As follow-up after an acute asthma attack, we will continue prednisolone until full recovery for a minimum of 5 days. We will arrange a GP review within 2 working days. We will monitor symptoms and peak flow regularly. We will check the patient's inhaler technique, provide a written asthma action plan, remembering that they have been shown to reduce morbidity and relapse rates. We will modify their treatment according to the guidelines for chronic asthma. And finally, we will address any potentially preventable factors and triggers that may have contributed to the asthma attack. So that is it, a review of the treatment of acute asthma in adults. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening and goodbye.